iron deficiency is one of the big four. Worldwide, a substantial part of the population has iron deficiency and anemia. We learned from your presentation on iron deficiency that there's one problem in an area where we have the malaria with iron supplementation. So we cannot go in and give iron to the whole population. There's a problem.
Correct, yes, yeah. It would appear that because all microorganisms, almost all, require iron to grow, then putting iron supplementation into a population where there is a very high burden of infection, especially malaria, but not only malaria, can lead to an exacerbation of those infections, more hospitalizations and so forth, and not necessarily successful amelioration of the hematological deficit.
You presented a very comprehensive overview concerning a new biomarker of iron deficiency, which is called Hepcidine. Can you elaborate a little bit on Hepcidine?
Sure. Pronunciations differ. Hepcidine is the preferred term to the American audience, and it was discovered by an American called Tom Gantz. At least he named it, and it was co-discovered by two other European groups. So although you've referred to it reasonably as a biomarker, I never think of it as a biomarker. It's a hormone. It's a determinant of iron absorption and iron utilization. So more hepcidine means that an individual will not be able to absorb iron through the intestine, and any iron that they do have will be preferentially sequestered in macrophages and not available for red blood cell synthesis.
Does hepcidine work for all age groups, or is it only for children?
That's an extremely interesting question, and I think to put it in perspective, hepcidine was discovered in about 2000, and we began to understand how important it was in 2005. We've only had an assay available to measure it in serum from 2007, 2008. So the field is quite young in that respect. So a lot of basic work on hepcidine normal ranges in different age groups, different genders, different populations has not yet been done, and we are doing it. But there are certainly important differences and changes so far that have been observed in aging populations, in premenopausal women versus men, and also in infants as well. So there are important variations in that which reflect the underlying physiological need for iron at different ages. So you need more iron when you're growing, and also the different iron use and eventual fate of iron in women versus men.
Final question. You said a hepcidine determination in the lab is approximately $10 or whatsoever, in that range. What is your estimate? How much will it be 2020? Because if it's 15 cents, everybody will do it.
Yes.
And it will replace all the other tests.
Well, I think it has to be driven by the clinical need and the biological understanding. And we're at the cusp now where I think more and more research groups are factoring in hepcidine analysis in their research as to the underlying pathology of a variety of different diseases, not just iron deficiency and anemia, but also heart disease, transplantation, response to hypoxia, and so on. And what I would imagine is that hopefully over time it will become more and more apparent that hepcidine is going to be useful as a guide for iron therapy in different health conditions, and that will drive the price of the hepcidine assay down. If that occurs, then yes, 15 cents is perhaps a little optimistic, but you never know.
Yeah, but with the costs in our hospitals, it's a factor when it's available as a commercial assay at a reasonable price.
Absolutely.
It will be very successful, what you have said today.
Exactly, yes.
Thank you very much.
Oh, thank you very much.